Thanks so much. It's great to be here today. When they told me that we were going to do TED-like talks, I was so excited and also a little worried. I was a little excited because it was a good chance to sort of think about what we've been doing for the last 4 years and to try to figure out if we could reach a new audience and package our material in a new way. And I was a little worried because, well, you know, it's hard for me to focus on something and try to think of one thing that I could tell you in 15 minutes that could really change the way you think about EHRs and this really complex field we live in. Electronic health records are really complex, and we've heard, I mean, everyone's already given my talk. They just haven't put it all together yet today. We've heard that how they should be like airplanes, the bathroom, the grocery store, and some people even say they should be as easy as an ATM. And all I can tell you in my vast experience of 30 years that EHRs are really not like an ATM. They're much more complicated. They're never going to be as simple as an ATM. So that got me to thinking even more about what we were trying to do, and we made this proposal to the ONC that we were going to build a clinical summarizer, and we had, let me just tell you, a grand plan about how we were going to summarize electronic records. I still think that's the most important thing that we have to learn how to do if we're going to be successful with EHRs, but it didn't take us long to realize that we had some problems if we were going to try to do this. And Adam talked a lot about some of our problems with data availability and interpretability of the information, trying to get it together, trying to look at the gaps in the knowledge that we had of what we're trying to do. And that's a huge problem in all of our EHRs. So when Adam and Ben had their great interchange, I think the answer was supposed to be that the partners system has more knowledge in it that makes the interface easier for the clinicians to use and more effective for the physicians. And so this knowledge is something that we're really missing in our computing and how to find it, and a lot of us have spent our whole careers trying to figure out how to get knowledge into computers so we can make them do what we want to do. There's a lot of limitations on the user interface, and we've heard a lot about that. And then we realized there was really no clear agreement on even what summarization meant, and we struggled with that. So mostly we found that we didn't even have the tools to answer these problems. And so one of the things we worked on was trying to develop some tools and think about these. And so the first one we came across was this idea of a complex adaptive system. And Bill Rouse had a really nice paper in around 2008 that talked about why healthcare is one of these complex adaptive systems. And these are things like the telephone network, the internet, biological systems. These are very, very complex things. And the thing that tells you is that theoretically it's not possible to break these down into what we call hierarchical decomposition, or break it down into the parts, solve the parts, and then put it back together and expect the system to work. Because when we break them down, we lose sort of the interconnection between the parts, and that's where the real function of these systems are. And so much of our work in informatics has been breaking things down and trying to solve it. And so we heard people talk about, you know, building decision support systems for one chronic condition when we know most of our patients have 2 or more chronic conditions. And so we have a simplifying assumption that allows us to do our work, which makes our results invalid. And so those kind of assumptions generally are particularly bad. So some of the properties of these complex adaptive systems that make them so difficult to study are this idea that they're nonlinear, meaning that a very small difference in inputs leads to major differences in outputs, which can make these systems seem like they're either random or chaotic in behavior, which makes it very difficult to study because you never get the same sort of response when you think you've got the same sort of inputs. These things are composed of what I'll call independent agents, and these agents can be either people or software or complex machines in themselves, and their behavior is not based on what I'll call system dynamics or mathematical principles or physics. A lot of it is based on physical and psychological and social rules, and these kind of things don't interact in the way we thought, and so it makes it difficult to study them. All of these independent agents are not the same. So when you go into the hospital, some of the agents are better than others, and some of them think they're better than others, and that makes it very difficult to understand what's going to happen. So I'm sorry Toby left. I thought he had the best answer of any question today when someone said something about those elevators. This is Joe, and he wanted those buttons in one place. And we always talk about the same thing with the EHR, like we all have our idea of the use case, and we know how to design the system to solve that use case. And there's always another use case, and I couldn't think of another one, but he did, and that made it difficult to do. So what we do in information or EHRs is we would put another button in the middle, another button in the the hallway, and then someone else would have another button by the stairs, and pretty soon there'd be buttons all over the place, just like we have in our EHRs. And so got to remember about those interaction systems. Now, all these agents are also intelligent, which means that they can learn to do things, and that means when they learn to do stuff, they learn to do things in a different way. And so we have what we call self-organizing behavior. And so some clinics will do things totally different than another clinic and get pretty much the same outcomes but have much different workflows. And that makes it difficult for us to study, which results in these systems being very unpredictable and almost uncontrollable. No one's in charge, and so no one can tell anyone else what to do. So some of the people I see are in the back are some of our people that are leaders that are in charge of their organizations, and they all know that they're really not in charge. They're just out there and doing their best and trying to get everyone to come along and do what they want them to do. And this idea of not being controllable, predictable, causes a lot of problems. So we tried to figure out what we're going to do with that. Even with all these problems, we know that health information technology can improve the safety and effectiveness of healthcare. We have some very good evidence in certain places where that's worked. We have examples like Scott Evans, who's my hero, with his computerized antibiotic ordering system at LDS Hospital. He spent the last 30 years building this system and getting it to work, and it's really effective, and it makes everything good, and it reduces length of stay and cost and saves millions of lives and things like that. So it can work. We see things like David Bates showing you can reduce errors with these systems. And my PhD project that showed even that you could improve respiratory care of patients. Another one that's been going on now for over 30 years. People have been working on this system to improve it, get it to work. So we started thinking about all this and trying to put it together. And this model we've developed sort of helps us to understand these problems. And we call this an 8-dimension socio-technical model. And I think we've talked about all the dimensions of this model today. So we've heard people talk about hardware and software, and Jim said that was called the form factor now. So we talked about iPads, we mentioned the Google Glass. These are the new kinds of hardware that we're trying to develop, new software that does that stuff, and we have to think about how that's going to change whatever we do. And we use this model every time we're thinking about a problem. We think, are we addressing all 8 dimensions of this problem? Because to get anything to work, we have to make sure that all 8 of them are working, and that's our biggest problem right now. The next version is the content. We heard Bob and David, David, I don't know how to say that last name, I guess, talk about how they're trying to build content. And David McCauley talking about putting content into these systems in a different place. We're going to do that, and this is the clinical decision support rules. It's the charting templates. It's the data that goes into our system that makes our system work. On top of that, we have our user interface, and the user interface is controlled by the content that goes into that user interface. That's what it's displaying. The systems that have the best user interfaces, in my mind, are the ones that have more clinical knowledge and content that tells them how to work. So they work better than others because they display the information in a way the users want to see it. Then we have the people that actually use these systems, and we've heard a lot about that we're going to train them better, that we've got to try to understand the different kinds of people, and we've got to remember they all have a lot of different uses, and so there's so many different people using our record systems that makes it difficult for us to use these systems. And then we have workflow and communication, and this is the place where we finally start to realize that healthcare is what I call a team sport. There's multiple people taking care of one patient and trying to get stuff done. And so Jack mentioned this social idea of an EHR. So when we started computers, they're called computers because they were calculating things. But it turns out the real benefit of a computer is really as a social communication tool. So we now use our iPhones to talk to each other. We don't use them to calculate, even though they do a lot of calculations. They're really communication tools. We're not using our EHRs well enough to actually influence the communication and workflow patterns in our hospitals. And then around that, we'll put what we call the internal organizational policies and procedures. This is the environment, the physical limitations. So we just saw Jan showing us that computer in a closet, like what a perfect place to put it because it's out of the way and it won't get in anyone's way. And whoever thought of putting it there, I'm sure went home and told his wife what a great idea he had today because I just found a place to put the computer and it won't bother anyone. And we do this all the time in our systems where we have a rule or a policy in our organization that says you can or can't do something some way, and that affects the way we build our systems. And then we have this huge external pressure. And so many times the answer in informatics becomes, well, that's the way we have to do it because that's the way we bill for it, and if we don't bill for it, CMS won't pay us, and if CMS doesn't pay us, we'll be out of business. And so every user interface discussion, every order set discussion, every alert discussion, a lot of it can be boiled down to we have to do it that way for the billing, and that's a bad reason to build our systems, but we have to think about what are the external pressures, and we've talked about the beauty of having ONC get some stuff into meaningful use that helps us, and so some of these regulations are going to actually help us. And then finally, you have to be able to measure and monitor what you're doing. And so Jan talked a little bit about that, of making some measurements in your organization, trying to understand what you're doing, and trying to allow you to measure and then manage what you're trying to do in your organization. So let's bring it back to our clinical summarization project. So we're thinking about that 8-dimension model. We're thinking about this complex system. We're building this clinical summarization tool. Like I said, this is one of the unaddressed grand challenges in informatics. I wrote a paper in 1994 about that when I got into an argument with my boss when he said something was a grand challenge, and I said that wasn't a grand challenge, and he said, what are they? And I said, these are them. And we wrote a whole bunch down. This is one of them, and it's critical that we learn how to bring data together, and as we get more and more data, this is going to be more and more important. So there's a lot of steps to summarizing data. I told you we didn't have a model, but now, after our project, we have a model of what it means to summarize. The first thing you have to do is aggregate the data, and that means bring it together from different places. And we have different kinds of data interchange standards. We have limitations of HIPAA. Sometimes they won't let us for that reason. We have organizational resistance to doing this. We have solutions that are nice and simple that have been in place for standards for over 10 years. This is the RIM version 3 model. Now, it's not hard to read. It's just complicated. And most people have not implemented this because it was too hard to do. And so we've come up with the virtual medical record, the healthy decisions, I can't even think how many alternative methods we've come up with. This would solve the problem, but it's too complicated. So we don't do that, and that's a shame. Then you have to organize some of the data. That means right now we organize data by alphabetically or by source of the data, or by time that we captured it. And that's not the way we should organize it. We should organize it according to the patient's problems. That requires a huge amount of knowledge, and that's where we spent all of our time on this project trying to capture that knowledge, and that will require some new user interfaces to use that knowledge. Once you get that, you can reduce the data. That's trying to figure out what data. So we talked about duplicates and trying to reduce those duplicates, and the twin list is an example of how to do that. You need to interpret that data and try to understand what it means, and then finally to synthesize it and bring multiple pieces of data together to know, like someone said, is that Lasix making the patient pee? That's what synthesizing the data means. That's what you want to know when you look at your EHR. We don't have any EHRs that are easy to answer that question right now. That's what I mean when I say summarization. We should be able to do that. We made a little model, a simpler model of how to, what kind of decision support. We got a little model of decision support, and this is what it would take if we wanted to build one of those national cloud-based systems that David McCauley talked about. We've worked on several projects. Adam and I just finished a big 5-year project where we built 2 rules at 3 sites in 5 years. 3 rules at 3 sites in 5 years for $6 million, and I don't think that scales up either. If someone said that it took someone 4 years to make one interface for one problem, this isn't scaling up either. So with that, I just want to remind you that we have to address this problem. We have to be able to summarize our data. Otherwise, we're going to make the problem a lot worse than it ever was before, because we have more data than ever before. And this is going to require a long-term commitment to a socio-technical approach. I'm glad to see everyone's here willing to help us, and we're looking for their 4 more years. Thank you very much.